Hello, my dear candidates. How are you all? Hoping all are well. Is that my voice is clear, doctors?
Yes, ma'am, it's clear.
Okay. Okay. Thank you,
Yes, ma'am.
doctors.
Yes,
So
ma'am.
first,
Yeah.
yeah. Today, my second gynecology session. Actually, I emphasize more for my prometric exam candidates, DHA, HAT, SLE, MOS, that after medicine, if we keep focus, strong point, and it will make sure that it's okay. 15 question, I have to make sure 10 plus question should be correct for my gynecology. So 15 question, if I correct from the gynecology, it carry more mark and it's easy. Because some question from orthopedic surgery is not easy. It's myself, my advice. Sometimes we are not practicing in surgery, sometimes hernia question, hernioplasty, hernia, though we are strongly discussing those topics, but eventually gynecology easy to carry more marks than other parts. As usual, medicine also, because we are practicing medicine part. So today I'll discuss from the gynecology very high yield topics. Today I'll discuss who will miss, better to listen more and more, because these are the topics they ask commonly in the exam. So if anyone difficult to see through PC or mobile, it better to upload my Zoom. Sometimes I am emergency duty. Sometimes I have to difficult to carry PC, so it easy to carry mobile or iPad. We can do so in Zoom downloading. So I faced this question from two candidates, so it's better through PC other than PC. So I'm starting my session today. Today my session from the puberty disorder, pediatric, adolescent, and young gynecology. Actually, commonly asking question in the exam. My MOH candidates, my heart candidates, and DH candidates, vaginal agenesis, Meyer Rokitansky Kuster syndrome. Actually, it's called Muller agenesis, Mullerian syndrome, or Mullerian agenesis. So, this exam question they ask commonly by clinical presentation. How they ask? First of all, they will give you a clinical scenario that a female karyotype is normal. So see my words and my sentences. Karyotype normal, ovary, uterus, function, all are normal, but secondary sexual characteristic like breast development, axillary hair, pubic hair, all normal. Okay. So presentation is primary amenorrhea. Presentation is primary amenorrhea. But whatever the thing is that I have to understand that vaginal agenesis or Mullerian agenesis karyotypically okay, genetically okay, but primary amenorrhea presentation. So what actually happened? Because ovarian function okay, breast development okay, puberty is okay, all developmental okay. So we have to keep follow, or we have to keep focus on the developmental, like uterine or vagina, or is that develop okay or not? Cause this question they ask mimically, two way they ask, that's why, and sometimes they confuse. In my general group I saw this way. Mullerian agenesis, this question. Actually, vaginal agenesis are congenital malformation characterized by failure to Mullerian duct to develop, resulting in missing uterus, variable degree of vaginal hypoplasia in upper portion. So, it's a developmental delay. My dear candidate, exam question, Mullerian agenesis, the primary amenorrhea question, karyotype 46XS, karyotype 46XS, and presentation is the lack of hypoplasia of the uterus, lack of upper two-thirds of the vagina. So, but ovary is normal. Actually, candidates are entering frequently. That's why I have to interrupt. So, it's sometimes interrupting when I have to allow them to enter. So, when my candidates will enter, kindly mute the mic. Okay. So Mullerian agenesis, testosterone will be higher. This point of view I have question cause sometimes they give this value testosterone normal, but why? Sometimes it couldn't be higher. Congenital androgen insensitivity syndrome or androgen insensitivity syndrome, the possibility of having the problem in hormonal dysfunction. So this chart I posted only for exam correction. Mullerian syndrome, they posted higher testosterone, and also who are giving personally with me mock exam, they asked me why ma'am it's not actually I'm discussing the question why not it's the test androgen insensitivity syndrome. So sometimes testosterone higher, this question I have to understand, is it Mullerian agenesis or androgen insensitivity syndrome? How? First of all, Mullerian agenesis is not a hormonal dysfunction. This is the problem of Mullerian duct. Vaginal agenesis. But all hormonal function are okay, ovarian function are okay, breast development okay. So if they misguide you by any way by giving testosterone high, don't be confused with compare with androgen insensitivity syndrome. I'll discuss. So it could be high testosterone, though this is exam question. It could be normal, or if they give FSH high or LH high, it could be. But it doesn't mean it is androgen insensitive. But commonly androgen insensitive question, though this is my exam correction question, androgen insensitivity question, FSH will be higher. These two questions, my many candidates misguided that high FSH, how androgen insensitivity syndrome. So this I'll discuss primary ammonia. If FSH higher, though testosterone will be higher here. It could be normal, but androgen insensitivity syndrome patient could be male, could be female. So this kind of presentation they will give many clue regarding the Mullerian agenesis androgen insensitivity syndrome. So see, in androgen insensitivity syndrome, best when I declare the announcement, the time of the session, best to enter the time, either it breaks commonly, okay? So androgen insensitivity syndrome, primary amenorrhea along with no pubic hair. So see, the presentation is not as Mullerian agenesis. Presentation is not same. I'm telling frequently exam question my every candidate course pubic hair. So in Mullerian agenesis, there's nothing difficult like that. Only this will see pubic hair normal, axillary hair normal, breast development normal, but here course pubic hair. Some I have not just I remember one question. My dear candidates, I frequently post recall because my candidates are posting me personally. Whether they whatever they remember from after coming back to the exam. But my session main aim to strongest your confidence. Okay, this is the point. Like I am telling regarding the fibrous and fibroadenoma and phyllos tumor. Though I was marked as fibroadenoma, it was not phyllos, but strongly, as I remember, in breast discussion topics in surgery, I discussed that fibroadenoma always soft, movable. It's a benign, but phyllos again goes towards it easily. It's a grow first, it's a hard towards it goes towards the phyllos. So whoever after coming back, they she or he sharing the recall and marking fibroadenoma and passing nicely. So remember, fibroadenoma question never be hard. So my strong point, if sometimes you can ask why ma'am this type of question, why you are, so I can explain this way because my main aim is to be, you have to be strong enough from your knowledge. So Mullerian agenesis, congenital androgen insensitivity syndrome, if you say testosterone high, only this one, it doesn't mean it's congenital androgen insensitivity syndrome. No. So we have to compare with other presentation, whatever the course, whatever the pubic hair, whatever the axillary hair, whatever the breast development. So this will be hampered in the congenital androgen insensitivity syndrome, like uh, stage 5 or stage 10 or stage 4, female come to hospital but breast didn't develop fully, there's a coarse pubic hair. So I can understand there's a problem in the hormonal imbalance, so I have to rule out like that way. Okay, so little or no axillary pubic hair growth, so only they give testosterone normal but FSH, and you are marking congenital Mullerian agency. No, you have to think the hormonal imbalance on complete androgen insensitivity syndrome. I will get those pictures, but it doesn't mean that only TSH high means it's androgen insensitivity syndrome. Maximum candidates doing these steps of wrong in my general group discussion. Though sometimes some restriction in my private substitution group in the mock session. So we can discuss one or two questions, no issue after completing the mock. So better to strongest your knowledge. So see the complete androgen insensitivity syndrome, my dear candidates. The you see the karyotype 46XY. Okay, so Mullerian agenesis syndrome 46XS. This also exam question. Both presented with primary amenorrhea. The laboratory findings I never did emphasize because laboratory findings always vary. My main point of view I have to differentiate by this picture. Lack of hyperplasia of the uterus, lack of upper two-thirds of the vagina. If they didn't give, but hormonal function is okay, breast development okay, axillary hair is okay. But in case of congenital complete androgen sensitivity syndrome, shorten of vagina, there's a coarse pubic hair, not development fully the breast. This is the goes towards the androgen insensitivity syndrome. Okay, Turner and congenital adrenal hyperplasia I'll discuss later because these are the congenital anomaly. Just regarding current Turner, there will be lots of presentation. I will discuss later. So these are the way we have to understand the Mullerian agenesis and congenital androgen insensitivity syndrome. So this picture, this chart will make you more confident. How? So see here, my dear candidates, always, first of all, we have to take history, we have to do examination, we have to do the hormonal profile, we have to do the pelvic ultrasound. Because why? We have to exclude what is ongoing. And if uterus present, yes or no? If uterus present, yes. So we have to do the hormonal function test. If LHFS is lower, it's a functional or primary gonadotropin releasing hormone deficiency. If it is higher, it's the primary ovary insufficiency. This is the exam question. Presentation very important. Primary ovarian insufficiency, congenital androgen insensitivity, all you have to face exam, but you have to be more confident because why uterus present but LHFS is high, it's a primary ovarian insufficiency. So we have to do karyotyping. It's a hypogonadism or not. Karyotyping, hypogonadism, Turner syndrome, we have to give or we have to see what are the presentation of the Turner syndrome, like short neck, then the cardiovascular problem, VSD, or quotation of aorta, like that way they will give many clue for the Turner. Okay, or congenital abnormality, same types of presentation of the her sister or brother, like that way. If normal FS is LH, we have to think regarding the outflow tract obstruction. So first of all, the presentation. After doing the hormonal profile, what we are getting, if is that not present in the uterus, so it's a Mullerian agenesis or androgen insensitive syndrome. So we have to do the karyotyping plus testosterone. Okay. Regarding the complete androgen insensitivity syndrome, so see phenotypically female, menstruation absence, external genitalia normal, vaginal depth short, not ovaries, atrophic testes. So she all developed, not well developed breast, but sometimes they didn't give the developmental deal of the breast. Sometimes the breast didn't develop fully. Because if it is male, complete androgen insensitivity, phenotypically could be female, phenotypically could be male, but remember it is phenotypically female, but it's a male actually. So there is atrophic testis, but there is a, we have to remember that these hands, feet all goes towards the larger like male. Because phenotypically, like phenotypic presentation is the female, but internally all hormonal imbalance towards the male, like hand development, there's a testis like swelling, vaginal depth is low, and there's no menstruation, testosterone higher, FSS LH could be higher or low due to that there is ovarian dysfunction. So genetically or genotypically 46XY, XY means what? It's a male. But presentation, is female-like. So this way we have to exam high yield topics for the exam: Mullerian agenesis and complete androgen insensitivity syndrome. So now practicing part one by one, because every question from the exam. So one by one I am starting practice. First of all, Dr. Donilla will do practice first question.
Yes, ma'am. 17-year-old female, no menstruation, high testosterone, normal breast development, coarse pubic hair. It's karyotype 46XY, I think, complete androgen insensitivity.
First of all,
Because of
Dr. Donilla, your point where? Your point is that normal breast development
yeah, and
high
coarse pubic
testosterone
hair and
and
high
coarse
testosterone.
high
Yeah,
testosterone, which goes towards complete androgen
complete androgen
insensitivity.
insensitivity. Yeah,
Yeah, excellent. So
yeah,
this one we have to understand is the exam question. Thank you, Dr. Donilda.
yeah. Thank you.
Second question will be discussed with me, Dr. Ikra.
Assalamu alaikum, ma'am.
Walaikum
Uh,
assalam.
17-year-old female, no menstruation, normal testosterone, normal breast development, and normal pubic hair. Ma'am, I think option A.
So what are the points for choosing option A?
Ma'am, normal pubic hair,
Here and normal breast
testosterone,
development.
and normal breast
Yeah,
development.
normal is, yeah, it's a Meyer, it's a Mullerian agenesis,
Yes,
right?
yes, ma'am.
Thank you, dear. Thank you, Dr. Ikra.
You're
Nicely
welcome,
done.
ma'am.
Yeah, yeah. Now, newly joined two candidates today, Dr. Sneha and Shruti. So, from I'm starting, I always discussed in the middle when I start my discussion. So, third question will be discussed with me, Dr. Shruti. Then I can understand they are listening. If Dr. Shruti is not here, Dr. Sneha.
Good evening, ma'am.
Okay, Dr. Shruti. Dr. Shruti, read third question and answer me what is your diagnosis.
17-year-old female, medically free, athlete, gymnast in her class, dressed later and never menstruated, undeveloped examination, she is scanner stage 5, but no menstruation diagnosis.
Dr. Shruti, you have to tell me, ma'am, these are the point I am thinking this could be. First of all, medically free are athlete patient come to your hospital. Okay. And complaining of I am gymnasian, I do gymnastics, so I have developed breast later stage. So I am 17 years, but breast developed later stages. I didn't menstruate, so still menstruation didn't started. And you done examination which revealed NRS stage 5. So why no menstruation? Question is not easy, Dr. Shruti, like Dr. First and second question. Question is really little bit hard.
Yeah.
Okay. If Dr. Shruti can't able, we can discuss with Dr. Kishori is here.
Yeah, I'm here, ma'am. I'm
Okay.
here.
Okay. So tell me what is your thinking?
Okay, ma'am. She's 17 years old and she's a sporty person. Okay. And she never menstruated, breast later and never menstruated.
Yeah.
She's on tenor stage 5. This is related with hypogonadotrophic hypogonadism. I think, ma'am.
Yeah, excellent.
Because
yeah,
okay.
because okay.
Because
Tell me expansion.
okay, because ma'am, like sporty, especially sporty female, they. I heard that, ma'am. They have to keep their diet restriction.
Diet
That's
restriction.
yeah. And even eating disorder, eating disorder, which hamper their menstrual cycle.
Yeah,
and
excellent.
That must be the reason. So
yeah, excellent.
Okay, ma'am, that's hypogonadotrophic hypogonadism. Okay. That's it.
Yeah. Actually, Dr. Kishore tried her best and excellently telling actually main main point towards the dietary restriction. As she is a gymnasian, she has to follow strictly dietary control, which goes towards not developing this gonadotropic hormone like LH, FH, estrogen, progesterone for improve the ovarian function, uterine menstrual cycle, there is estrogen, progesterone, hormonal secretion. So all is from the anterior pituitary. So when you strictly maintain dietary function, it develop hypogonadotropic hypogonadism. See, I said here that menstrual cycle disturbance, delayed puberty, amenorrhea, oligomania. So see the highlighting point I am reading, the presenting symptoms goes towards the hypogonadotropic hypogonadism. Young women, adolescent, eating disorder, amenorrhea may have prepubertal luteinizing hormone delay. So when it causes pulsatility, sometimes upper, sometimes lower, this causes hypogonadotropic hypotension. This red, I mark already this yellow words. Just remember, if delay puberty, amenorrhea, whose young women, adolescent, okay, with eating disorder, amenorrhea, so this LH function pulsatile in nature. So this LH function when pulsatile in nature is called hypogonadism, because she is not able to regulate the menstrual cycle. So heavy, severe dietary restriction, excessive exercise, okay, this participation of athletic activities which goes towards risk factor for disorder of eating. Thank you, Dr. Kishori, you done very well. So when the gymnastic, this is the exam question, fully exam question, my dear candidates. I will post this PDF later. My strong advice, the collection of my post on the PDF question is you have to remember the topic wise, because these are the recall also. So you have to remember that if any point goes towards the athletes gymnastic, we have to remember hypogonadotropic hypogon, even whatever the hormonal dysfunction they give is not my headache. My headache patient is gymnasium. That's it. You can't remember, it could be androgen sensitivity. No need to remember regarding, because I have to strong enough. It's a gymnasium, so it's a hypogonadism. That's it. Another point regarding the complete androgen sensitivity, as I said, that 46XXY is the genotypically, but phenotypically is a female. So presentation will be all hormonal dysfunction. Okay. Another very strong point for the exam is the acute abnormal uterine bleeding. Kindly mute the mic, okay? When my candidates will enter, please kindly do mute the mic. So abnormal uterine bleeding. Abnormal uterine bleeding, we have to remember that heavy menstrual bleeding. Presentation and management, we have to remember. Abnormal uterine bleeding, bleeding from the uterine corpus that is abnormal in regularity, volume, frequency. So abnormal in regularity, volume, frequency. And the duration is not okay, and absence of pregnancy. So see, the presentation means after a menstrual cycle, within this second menstrual cycle, if present in hospital, heavy bleeding or unusual bleeding which is not expected, which is before the next menstruation within the 2 to 3 times, we have to remember this abnormal uterine bleeding. Abnormal uterine bleeding patient come to with me either heavy bleeding or frequency of bleeding more than usual. So acute setting what means heavy bleeding. I have to resuscitate the patient for initially fluid. If hemoglobin dropping, we have to do blood transfusion. Medical management, initially we have to give what? Tranexamic acid or mefenamic acid initially, but we have to keep follow up the patient, and if needed I can give the IV conjugated equine estrogen, primary choice for heavy bleeding. So IV conjugated equinestrogen, IV conjugated estrogen, we have to remember as it's the definitive management or oral contraceptive pill if less severe bleeding. So IV conjugated equinestrogen, primary choice of heavy bleeding, but if less bleeding, we can choose combine. This way we have to remember, my dear candidates, remember strongly. I always strongly advise keep a short note. Before may extremely my every mashallah alhamdulillah all are passing. Do short note what I am telling, because this point you may forget. Like I one few countries may asking why not a mechanical ventilation, why not BiPAP CPAP. Actually I only said just see the carbon dioxide value. Only carbon dioxide value will guide you, either you will do MV or BiPAP CPAP. Strongly I said do a short note before start. When you do or when you give your final exam, it will be easy to revise them. That these are the higher topics ma'am also discussed. This way I have to option levonorgestrel. What you will choose?
I'll choose levonorgestrel.
Because there is a severe acute setting bleeding, right? But in option there is
Yes.
no. So we have to choose
No.
OCP. Okay.
Yes.
Excellent, Dr. Yes. Excellent done, Dr. Solomon. I'll discuss later. Thank you, Dr. Solomon.
All right,
Second
thank you.
question will be second question will be discussed with me, Dr. Reza.
Hi, ma'am.
Yeah.
About 28 years old, came to ER with heavy vaginal bleeding. She is nullipar. Nulliparous pregnancy test negative, no pain, regular sick, but always with menorrhagia. How to stop the bleeding now? Came to ER, emergency, heavy bleeding, and she's nullipar, pregnancy test negative, no pain. And regular cyst is a sudden menorrhagia. I think there isn't any history back on. I think it must be how we can stop. Give conjugated estrogen, give progesterone, give GnRH, insert a levonorgestrel IUD. I think it must be controlled as soon as possible with conjugated estrogen.
Okay. Conjugated estrogen you have to give initially, right?
Yeah. Yes.
Due to heavy bleeding, right? Okay.
Yes. Yes. Yes.
Okay. Excellent done, Dr. Reza. Thank you, Dr.
Thank you.
Reza. I'll discuss.
Thank you.
Yeah.
Thank you.
Third question will be discussed with me, Dr. Saba Jisan.
A female patient presents with a heavy pervaginal bleeding. Her bleeding is associated with pain and of large volume. Upon vaginal examination, you noticed pooling of blood. Pregnancy test is
Okay. Pregnancy test is negative, her BP low. Okay.
her BP.
Is that okay to read, Dr. Saba? Pregnancy test is negative, BP low. Is that okay? Now you can read.
It's disappear on my screen. Yes,
Okay,
now visible. BP low, labs RBC is low, HP low. What is your next step in the management? A, progesterone. B, conjugated estrogen. C, blood transfusion.
First of all, Dr. Saba, you have to discuss this question with me with stepwise. First of all, what is the patient condition? You are doctor of the
Patient
emergency. Unstable.
Yes, ma'am. Patient is unstable with, yes, ma'am, with a heavy bleeding, and also patient is in a pain.
Yeah, pain. So I have to manage right
First,
now.
yes,
is it medical management or another management? What do you think?
Ma'am, first I have to manage his pain.
But they say what is the
Stable,
next?
and then
Okay. Or what is the next?
Ma'am, I prefer for the blood transfusion to make him stable.
To make him
See?
stable blood transfusion you want to do, right? Because
Yes, ma'am.
next step they ask, so we can give, so hemoglobin is low is the point, very important point. I have to do managed by stabilization, right?
Yes, ma'am. Yes, ma'am. We do with the ABC airway, blood transfusion, ABC breathing and circulation. So there is a point C, which is blood transfusion to maintain his circulation. So I prefer the option C to stable the patient.
To stable the patient, as patient is unstable, we have to start first fluid, but there is no fluid option. I have to give blood transfusion initially, next step. Then we
Yes,
can
ma'am.
do admit the patient, we can start IV conjugated, Dr. Saba, IV conjugated estrogen I can give to settle the bleeding, right?
Yes, ma'am.
So first of all, step what I discuss with you. First of all, how we manage? You said stabilize. I have to do stabilize the patient, blood transfusion, then IV. As I am a doctor of the hospital, I can give IV conjugated estrogen. Definitive management. Is that so, Dr. Saba? Definitive
Okay,
management.
ma'am.
I have to give IV conjugated equivalent estrogen, but they said next means I have to settle the patient first. So answer is blood
Okay.
transfusion. Next, second, if they ask the definite this picture, you are the image channel. That's why I'm discussing, because this is the actual image question. If they said definitely, I have to give IV conjugated estrogen. Okay, Dr. Saba?
Okay, ma'am.
Yeah. So three questions I already discussed. Nicely done, my candidates. Nicely, really. And the discussion regarding the Solomon question, that regarding the OCP after evacuation, actually patient acute uterine dysfunction bleeding come to my hospital and patient in productive age, but we done evacuation. Okay, we done evacuation, but regarding this management, the in my option there is a no IV conjugated estrogen, only they give oral contraceptive pill. So less severe bleeding we choose oral contraceptive pill. So less severe bleeding, if we have to choose OCP, in my option there is no conjugated estrogen, we have to choose this one. And management according to the steps: first settle the patient, then manage accordingly mefenamic acid, tranexamic acid, and according to the bleeding dysfunction. Question 5 will be discussed with me, Dr. Sneha.
Good evening, ma'am.
Good evening.
Patient with uterine bleeding, what is the most appropriate investigation?
Uterine bleeding. Patient come to your hospital with uterine bleeding. So you are a doctor, what you can think initially? Initially, what you will suggest to do?
Um,
First, see,
CBC.
you are no. So see, actually, as we are a physician, we have to do our job. A patient come to, we don't know, but patient complaining of, ma'am, I have uterine bleeding, but is it regular menstruation or is it any implantation of the pregnancy? We don't know. Initially, we have to check what, Dr. Sneha? Not CBC. We have to confirm, is there any pregnancy or not?
We can do we should do an ultrasound.
Initially, they said
Beta
what is the
HCG?
most beta HCG. We have to do
Okay.
first confirm beta HCG first. Okay, Dr. Sneha?
Okay,
Because
ma'am.
we are the physician, patient come to my clinic that, ma'am, I have unusual bleeding. It can be implanted within sudden patient conceive, but patient don't know. So we have to do beta HCG first.
Right,
Okay?
ma'am. Thank you.
Okay, okay. Second question, question 6 will be discussed with me, Dr. Sachma.
Yes, ma'am. Excuse me, ma'am. Sorry. for interruption. Why we done with the beta HCG?
I said a patient come to your hospital. You are a doctor. I am your patient. I'm complaining that I have unusual bleeding, but you don't know cause. Is it menstrual? Is it intermenstrual? Or is it implanted? Whether I'm pregnant or not, I don't give any history. So you have to do beta HCG. Is unfortunately any pregnancy ongoing or not? Is that implantation or any abortion? So first of all, we have to be ensure, exclude the pregnancy because we have to be safe because we can do many things, CBC, ultrasound, because it's not my fact. I have to ensure whether patient is pregnant or not. Because CBC ultrasound, it's not my issue. So I'm complaining, ma'am, I have a bleeding. So you have to ensure whether I am pregnant or not first, because I am on reproductive age. So you have to ensure is okay. It's not a pregnancy-induced bleeding. It's another bleeding. So we can do the CBC ultrasound to check other origin. Clear?
Yes, ma'am. Clear. Thank you.
Question 6.
A patient with intermenstrual bleeding, what is the most appropriate investigation?
So see here clinic so you see they said intermenstrual. So I say, Dr. Sachma, your question, and you will answer that. I am telling my menstruation was 15th, now it's 20. So within second menstruation, there's a bleeding. So you have to do BTSCG or not? Is that possible within 10 days any pregnancy or not? Just tell me. Is the basic.
I don't think it's possible.
You can't think. No. It's a basic. It's not possible after one menstruation, intermenstruation. This word very important. This word very important. It's not possible within a missing period having a pregnancy. So what you have to do?
I would
Because I
ask
already.
for a CBC.
Why, my dear candidates are very concerned for CBC? Why? What do you see, my dear candidates? By CBC, what they will give value? Tell me.
Actually, I'm confused between 2 points because in CBC, anemia can also cause frequent menstruation, but thyroid function test will be also an option because if there is hypothyroidism, there is menorrhagia. So I'm stuck in between these 2 points. But
CBC only give hemoglobin level. It's not a factor. Never. It's nothing mandatory to do. Only hemoglobin level I can see. Nothing. This not give any pathology whether it have ongoing or not. Okay. I can do thyroid function test or ultrasound. They said what is the most appropriate. They didn't ask what is the next. Next me I can see
ultrasound will be the most appropriate of all.
most
I
appropriate.
think.
Yeah, it's the most appropriate. So two questions Dr. Sneha and Dr. Sachma discussed. Most appropriate for intermenstrual bleeding answer is the ultrasound. For intermenstrual bleeding, I can't think regarding the pregnancy, but they say patient suddenly come to your hospital with uterine bleeding. I have to make sure is it the pregnant or not. But when they give this clue intermenstrual bleeding, my SLE candidates, we have to make sure is the what about the appropriate ultrasound finding. So see what they say. Beta HCG question regarding the I discussed with Dr. Sneha. Beta HCG according to the guideline we have to exclude pregnancy, but it can cause reproductive age. And Dr. Sasma's question intermenstrual bleeding. Intermenstrual bleeding mainly caused by uterine and cervical etiology. CBD would be initial, would be. So CBC could be, TF thyroid function could be initial, but most appropriate. So see why not BTCG? Intermenstrual bleeding, menstruation within one cycle to another cycle, it not goes favor for the pregnancy. So we have to do primary imaging ultrasound to see the imaging whether any pathology in uterus or cervix. Clear, Dr. Sasma and other candidates?
Yes, ma'am.
So See, abnormal uterine bleeding question, heavy menstrual bleeding, intermediate menstrual bleeding. So non-structural cause, structural cause. Structural cause, menomesis is sperm, polyp, adenomyosis, leiomyoma, submucosal myoma, and malignancy. So in case of non-structural, is menomesis cone. Cone is the coagulopathy, ovulatory dysfunction, endometrial dysfunction, iatrogenic cause or not yet classified. So see, abnormal uterine bleeding pathology, whether it's a leiomyoma, is an endometrial hyperplasia, adenomyosis, what would be the cause? So my dear candidates, we have to rule out endocrinopathy, polycystic ovarian syndrome. If they ask intermenstrual bleeding initially, or what is the next? If they give the FSH LH value or on any hormonal dysfunction or any third dysfunction, you can mark it. But definitive or next appropriate always is ultrasound. And whether if they didn't give this clue intermenstrual, we have to choose beta HCG as patient on reproductive age. Primary dysmenorrhea question. So remember this way, primary dysmenorrhea, we have to remember the first of all we have to do evaluation. So cramping pain before or during a period, pain tends to lessen after first 3 days of period. So primary dysmenorrhea, in the absence of any pelvic pathology, there is no pelvic pathology there. We have to determine whether patient has primary or any suggestive pathology there. So secondary amenorrhea, there will be the reproductive organ, any disorder. So secondary cause, we have to remember any histological evaluation and endometrial or any myometrial organogenesis or any hyperplasia or dysplasia present or not. So primary amenorrhea, secondary amenorrhea, first of all we have to remember that what they given the scenario. Okay. Management is the exam question, but before that, history to determine whether patient primary dysmenorrhea or symptoms suggestive of secondary dysmenorrhea. So history important. First of all, question exam, how you will determine. So we have to take the history. Symptoms only primary dysmenorrhea. If primary, you can do pelvic examination, but it's not so necessary. Only clinical sign important. Primary dysmenorrhea. Secondary dysmenorrhea disorder is a reproductive organ disorder. The pain tends to get worse over time. So it's a reproductive organ disorder. Pain get worse over time. It often lasts longer than normal menstrual cramps. So when after initially first day there's a pain, it's okay, it's a physiological, but if it is persists, so we have to do evaluation. What is ongoing? Is there any endometriosis? Is there any adenomyosis? What about the histological findings? So we have to remember. Exam question regarding the management. First line always exam question NSI. Second line, if trial NSI does not respond, commonly patient exam question, we have to give OCP if NSI is not work. Now practice. Dr. Somia, first question, Dr. Somia.
Yes, ma'am. Female patient complaining of pain before menses and resolved in third day of menses. How do you diagnose it? A. Stereoscopy. B. Abdominal ultrasound. C. Clinical symptoms. Pain before menses and resolved in third day of menses. It's most likely primary. I will go with C. Clinical symptoms.
Cause it's the physiological. Third day of menses.
It's a primary dysmenorrhea, so I will diagnose with it by clinical symptoms.
Yeah, it's a primary dysmenorrhea, so you have to do diagnosed by clinical symptom. Thank you, doctor. Excellent. Thank you. Second question will be discussed with me, Dr. Hira.
Yes, ma'am. A patient with severe abdominal pain with menstrual cycle dysmenorrhea affecting her work. What can you give? Misoprostol, NSAID, progesterone, OCP. Ma'am, it's NSAID B.
First of all, why NSAID? Because they asking that this pain affecting her work.
What? Yes, ma'am.
So we have to give initially NSAIDs.
Yes, ma'am.
Okay. Question 3 will be discussed with me, Dr. Ifada.
Yes, ma'am. Patient with severe abdominal pain with menstrual cycle dysmenorrhea affecting her work. What can you give? A. Misoprostol, B. paracetamol, C. progesterone, D. OCP. I will go to OCP.
Why?
Because first, this is dysmenorrhea. We can give NSAID first, but here there's not NSAID, so we can go for OCP.
Excellent. These two questions, Dr. Hira and Dr. Ifada discussed. So see, Dr. Ifada nicely say, ma'am, I can give NSAID, but there is no option NSAID, so I can give OCP here, right? If NSAIDs here, I have to choose initially NSAIDs option, right? So see your discussion regarding the third option, NSAID first and OCP second, right? So you have to choose accordingly. Dr. Here choose NSAID first because it's affecting the work, and there is an NSAID option. So we have to choose appropriately NSAID. But if this question, the patient on NSAID is not working, so then we have to give OCP another way, right? Question 5 will be discussed with me, Dr. Nipuni. Dr. Kutsia. Question 5.
Yes, ma'am.
Yeah.
36 years lady with secondary amenorrhea, elevated FSH and LH, which of risk or complications she might probably develop in future? Risk of endometrial cancer, risk of ovarian cancer, risk of osteoporosis. Ma'am, risk of endometrial cancer. Option A.
Elevated FSH, LH. 36-year-old secondary amenorrhea, elevated FSH, LH. Spontaneous ovarian failure, right?
Ovarian. Risk of ovarian cancer.
No, it's a diagnosis is elevated FSH, LH means what?
Ma'am, premature ovarian failure.
Premature ovarian failure. So if a patient comes to hospital this way, which leads to what? So young, so young.
Ma'am, it's it increases the risk of endometrial cancer, ma'am, because of secondary amenorrhea, and FSH LH is also high, but she cannot menstruate.
Actually, high FSH itself is cause. Okay, this question for discussion, just for information, whatever my other candidates, Dr. Priya or Priscilla.
Yes, ma'am.
What do you think? The patients, your investigation, you are finding elevated FSH LH. What is the risk of complication in future?
She's having menopause now.
Let's say A option, endometrial cancer, ovarian cancer, osteoporosis. What is your answer?
Oh,
Your question 5. Voice is breaking, right? Voice is breaking. Actually, when FSH high, thank you, Dr.
Primary, it's the primary
It's
ovarian failure,
a
right?
primary ovarian failure. Yeah, it's
Yes,
a primary ovarian
because
failure. Yeah.
the primary
If
ovarian
FSH high
failure,
failure,
the ovaries stop functioning before the age of 40, and
yeah. So it goes towards
risk of osteoporosis.
osteoporosis. So goes towards osteoporosis because A is very younger. If FS is elevated, it causes osteoporosis. Okay. Thank you, Dr. Kishori. This way we have to think primary ovarian dysfunction, endometrial cancer, this further late complication. But initially, a female patient commonly when hormonal disturbance, even see postmenopausal, when FSHL is not working, 100 of patients comes towards the back pain, knee pain due to the osteoporosis, but they don't come with this cancer presentation. Even it's still and multiple patient don't know whatever the FSH and ALH function, what is the primary ovarian function, they don't know. They are carrying their duty of the life. But you see, every kind of patient in early or later stages come to with osteoporosis, back pain, this lumbar sacral pain or knee pain due to this hormonal imbalance. Okay, because lots of moms are not aware of their hormonal dysfunction. Okay, doctor, clear? Doctor, I was discussing this question with Dr. Kutse. Dr. Kutse, clear?
Yes, ma'am.
Okay, so
Thank
this
you.
was the future. In future, patient develop osteoporosis. Okay, this contraceptive method, this PDF will be posted after my session. There's a lots of arguing regarding the contraceptive. Though I discussed in my first session, as I remember, just for highlighting, always remember few points. Though I discussed, actually, I'm not. I did not discuss everything. Iodine device. Okay, this intrauterine device including copper and levonorgestrel. Okay, so these are the long time. We can give the pill, progesterone only pill, and implant, but it when we have to give. So remember some risk benefit ratio, some indication contraindication we have to remember. So before I want to discuss few questions, so it will be nice if we discuss, because many candidates asking, because these are the exam question. I already discussed this topics in first session. So if we discuss, it will be more easy. Why we are using OCP, why we are using IOD. So I posted few questions. I will discuss from first from Dr. If Dr. Nipuni not able to talk, so question can be started from the Maha Umer.
Yes, ma'am.
First question. Just I will discuss few questions for this multiple confusion here. That's why.
Patient with hypertension, heavy bleeding, and anemia, what contraceptive she can use? A. Tube ligation, C. Condom, D. OCPs. Madam, OCPs, because in this scenario, heavy bleeding and OCPs is used for contraception, and as well as it may be used for heavy bleeding menorrhagia. So the
But
option
what
D,
about
OCP.
but what about patient is hypertensive? You are not thinking this patient is hypertensive. Risks of what? Risks of stroke, risks of MI. So is it applicable here if you give OCP? This is the basic. So what we have to choose? Here B
Ma'am,
option was IUD. Here B option was missing. B option was IUD.
IUD, ma'am. B option.
B option was IUD.
Intrauterine device.
Intrauterine device. Actually, this B option, if you see tubal ligation, condom, OCP, and IUD, so we have to mark what?
IUD.
IUD. Clear? Due to the patient only their clue, whatever the thing. My clue is I have to save my patient life. If I say I'm your patient, I have migraine. Which one you will suggest for my contraceptive? Is it applicable? You choose me or you give me OCP or not? In migraine patient,
No, ma'am.
migraine patient, OCP is
No,
contraindicated.
ma'am.
So hypertensive patient, OCP is contraindicated.
Contraindicated.
Okay. Okay.
Negative.
Question 2,
Okay.
thank you, doctor. Yeah. Question 2 will be is a Muhammad something, Muhammad Umes Sahajat.
Yes,
Question
ma'am.
2. Yeah. Question 2.
Regarding injectable progesterone, which of the following is correct? Can cause skin problems
Yeah, very easy
associated
question.
with
And yeah.
irregular bleeding and weight gain, decrease in bone mineral density, delayed fertility after discontinuation.
First of
I'm
all, Dr.
option
Umar, see
Yes, ma'am.
what you first of all, Dr. Umar, injectable progesterone you are giving your patient. Okay. So A, B, C, D, my advice that you have to do excluding method. Okay. So your answer what I am telling you. What is your answer? Approximately what could be the answer? Approximately. Just tell me, ma'am, it could be. Then I am telling you why not, why not. Okay. Tell me.
It can
Or
cause
read.
skin problems.
Okay. A, and you are reading the option or you are answering me?
I'm telling you the answer.
Okay. Okay. Your answer is skin problem, right, Dr. Umar?
Yes, ma'am.
So it is not. Why? A patient, a female patient come to your hospital. A pill common presentation is never skin problem. Never. A pill, if it is injectable, we have to keep on mind many clue. It could be the intrauterine bleeding presentation, it could be the weight gain, it could be the low being a bone mineral density or osteoporosis. So they said which one of the correct? Skin problem never possible. Any kind of pill, hormonal control, irregular bleeding, weight gain, progesterone, commonly it don't do. But OCP, if I say Dr. Umar, your patient on OCP, what is the accept? Is what is the correct? So you can say, yeah, ma'am, weight gain is an OCP common complication, irregular bleeding is a common complication, but we give OCP in irregular bleeding patient for regulate the cycle. But common complication is weight gain. So you are thinking it could be the OCP complication, but my question is injectable progesterone. So if you're thinking, ma'am, what about the decreased bone mineral density means osteoporosis? It's a common complication of progesterone, Dr. Omer. Okay. Delayed fertility after discontinuation, it's never. After discontinuation, never it develop delayed fertility. Commonly, if you don't know the answer, if basic knowledge if I do apply here, is skin problem not possible either B or C, but I am confused whether it is OCP or progesterone. So I have to know progesterone complication and OCP complication. OCP commonly cause pulmonary embolism, commonly cause this thrombotic complication, commonly cause weight gain. But there's no option like that. There's only said progesterone. So I have to think is the bone mineral density decrease is cause osteoporosis. Clear?
Okay, ma'am.
Dr. Umar? Okay.
Yes, ma'am.
Question 3 will be discussed with me. So Priscilla Pushpam.
Yes,
Okay.
ma'am.
Okay.
Nullipara with menorrhagia and dysmenorrhea. What is the type of contraceptive appropriate for this patient? POP, OCP, Depo-Provera injection, NSAIDs. So she does menorrhagia and dysmenorrhea. I would choose Depo-Provera injection.
You will go for Depo-Provera.
Yes.
That's so what actually nullipara, right? Nullipara. Your patient is nullipara and dysmenorrhea, but there is a menorrhagia. Doctor, see, common thing. I am your patient, menorrhagia patient, and dysmenorrhea patient. Is there any role of Depo-Provera? First of all, both I can control by one contraceptive. Appropriate contraceptive. Nullipara patient, because I have to manage, I have to increase the fertility, I have to improve the menorrhagia, dysmenorrhea, and I will improve the contraceptive also. All together. Only one answer. Only one
Then
can
it's
do all. Then it is
OCP.
excellent. Then it is OCP. So first of
Okay.
all, patient nullipara. I have to improve it. And but patient one contraceptive. Okay, fine. Nullipara, but patient one contraceptive. But patient have menorrhagia, dysmenorrhea. So I will give a medication or I will give a pill which will cover all. Okay. So it is OCP, which this levonorgestrel long term, but it will not cover this menorrhagia, dysmenorrhea. We don't give so. Okay. Dr. Umar Sajad question was this: decreased bone mineral density. So see the progesterone the complication, bone loss. Okay, this irregular bleeding. So but there is a weight gain, so it will not be like that for the progesterone. Okay. Another IUD Mirena was question I discussed regarding hypertension. So in case of hypertension, we can't give OCP. We have to give IUD. This question just posted only for discussion. Today I'll discuss few questions. Those very important. Okay, Dr. Hira, no issue. This question one will be discussed with me. This every question I'll discuss today. Fatima, first Fatima DHS, second is Fatima Ahad question. Ahad candidate. One and two. One, Dr. Fatima Perry. Is that my voice is clear or not?
Ma'am, I'm sorry, ma'am. I cannot speak now. My kids are
Okay.
making some.
Okay, no issue. Another Fatima is able to talk with me or no?
Yes, ma'am.
If you are able to talk, you can. Neither it's okay. No issue. No issue. No problem. Okay. I think you have also problem. So better we can discuss later. No issue. So first question from Dr. Badhan. Second question, Dr. Moshumi.
Yes, ma'am.
Mhm.
Question 1. Patient with cardiovascular disease. She wants contraceptive. What type of contraceptive appropriate for this patient? IUD, OCP, progesterone only pill, and condom. First of all, as a patient is has cardiovascular disease, so OCP is not the answer. Then what's appropriate for this? Here, no clue. She wants
First of
contraceptive,
all,
but
cardiovascular. So you already excluded OCP is not possible. But
yes, ma'am.
I have to do excluding method if I don't know. So my other option is the POP, condom, and IUD. So what I can give this patient. So what is your answer?
I will go for condom. As here nothing mentioned. Either she
Condom is
wants long
not because
term.
there's a risk factor because there is a chance of there's a failure rate is high. So it's not.
Then
Okay,
it's also
OCP not.
excluded.
Okay.
Then IUD, I will prefer IUD, intrauterine device.
Intrauterine device is the most specific in cardiology or cardiovascular patient, MI patient. I can't prescribe, I can't I never can say using condom or progesterone pill also, because 3 are excluded. But AMI patient, pulmonary embolism patient, valvular heart disease patient, they can't use 3. All are the risk factor.
Yes.
OCP, POP, all are the risk factor for having thrombus. So it is excluded, and condom itself cause excision, so it's excluded. Okay. Thank you.
Okay, then answer is intrauterine device. Thank you.
Yeah. Dr. Pallavi is here.
Yes, ma'am.
Question 2.
Question 2. Patient underwent total hysterectomy with bilateral oophorectomy. When to give her? Total hysterectomy with bilateral oophorectomy.
So patient already
Estrogen
done
pad.
all.
Yes.
Okay.
Yes, ma'am.
So
Yes,
I
ma'am.
have to what? I have to
Estrogen pad.
improve estrogen pad. Okay, excellent. So why estrogen pad, Dr. Pallavi? Do you know why?
Ma'am, total hysterectomy is done, and oophorectomy due to bilateral oophorectomy.
So we have to give hormonal replacement. Patient is a
Hormone
candidate
replacement.
of hormonal replacement.
Hormone replacement.
All
Yes.
done. So we have to give estrogen patch. Excellent, done,
patch.
Dr. Pallavi. Yeah, excellent.
Thank you, ma'am.
Yeah. Question 3 from if Dr. Monia present, it's okay if you can talk.
Yes, I can talk.
So
Next
question 3.
question is,
Mhm.
yeah, mother just gave birth exclusively breastfeeding, one contraception for 2 years. Which one is the best? The Depo-Provera, POP, OCP? It is the Depo-Provera. Every 3 months and giving breastfeeding. So OCP cannot be given during breastfeeding. And for 2 years, so better Depo-Provera.
Okay. So you already actually answered question 4. Okay, no issue. Its answer is Depo-Provera. Fine, excellent, done. So patient, no issue. It's question 4 is Depo-Provera is the answer, that exclusive breastfeeding mom have to give Depo-Provera medication. So you another question 3 will perform again. Question 3 for you. Both question. Okay.
30 years woman asking for effective and reversible contraception. Which will be the following is most effective? Vaginal ring containing hormones, female condom, male condom, spermicide. Which will be the most effective and reversible
So they
contraceptive?
ask reversible. They ask reversible, right, doctor? So we have to
Yes.
remember this reversible is actually the clue is reversible. Actually, we don't look this word. If this word we see, we have to think what is the reversible method. Okay.
This male condom will not affect even in the ovulation. So no matter it is reversible or what, male condom.
Most effective actually in UAE exams, sometimes we don't practice as we know or as we think. That's why this is the exam question and this is the critical question. First of all, reversible method, asking for 30-year reproductive women asking of effective and reversible method of contraceptive. Which of the following? So most effective always male condom, female condom, how has failure rate, more failure rate.
Yeah.
More failure rate. Okay. So the answer is what? Spermicide is not reversible. So
no, it's vaginal.
female,
Then vaginal.
so it's a vaginal rate. Clear? Dear, actually we have to do what? Is a female condom, male condom both has failure rate, so we have to choose best one. Which is best one? Is a vaginal ring containing hormone, right? Okay, excellent done, dear. Yeah, thank you. Thank you. Nicely done. Question 5 will be discussed with me, Dr. Madiha Bhatt.
Yes, ma'am.
Yeah.
A
Question
healthy
5.
young lady just delivered a baby 4 months ago. However, she tells you that she does not want to get pregnant for the next 2 years. What method of contraception will you recommend?
So, Dr. Madhi, you will not just tell me the answer. You have to tell, ma'am, these are the thing and these are I am thinking. So, what? Actually, patient want 2-year contraceptive means long time.
Long.
So straightforward question.
Depo-Provera injection.
So it's a Depo-Provera. It is the answer cause patient don't want to be get pregnant for next 2 years. All question exam question I'll post later. Okay. Thank you, Dr. Madiha.
Ma'am, sorry for interruption. Is the vaginal ring is IUCD? I can't get it.
Vaginal ring, actually reversible method is not IOCD. Vaginal ring containing hormone is another type of hormone. It's not IOCD. IOCD we have to implement. What is IOCD? It can be copper type, it could be any hormonal type, just device. But vaginal ring is another type of hormonal contraceptive. Okay, it's not IOCD.
Okay, ma'am. Okay, thank
Question
you.
6. Yeah, question 6 will be discussed with me. Question 6 will be discussed with me, Dr. Dr. Monir is here. Dr. Monir.
Yeah.
Yeah. Question 6.
28 years old female known to have an ovarian cyst came to your clinic asking about contraception. Which of the following method is most appropriate for her? 28 ovarian cyst. Appropriate OCP, A, DHA, or progesterone only pill, vaginal ring, male condom. It could be A, OCP.
Okay. So what are the clues to choose OCP here?
As young 28.
The patient has cyst, Dr. Monir. Is that indicated or contraindicated?
Ovarian cyst.
Is it indicated or contraindicated?
Contraindicated.
No. It's not contraindicated. It's indicated because a patient, PCOS patient, polycystic ovarian disease patient, come to your hospital. You have to give OCP. So it is indicated. It is a clue. Okay. That there's cyst present. I have to regulate her cycle so I can give OCP. Clear?
Yeah.
Okay. Okay. This question, exam question, the contraceptive method appeals lots of questions. Just I discussed many questions. Now, this just for exam question, I'm discussing this question from Dr. Saba Jisan. Folic acid question, question 12. The
Indication of ovulation with
folic acid quantity for healthy lady who wants to conceive with prior disease or disorder. What is the value?
folic acid quantity for a healthy lady want to conceive and with no prior disease or Ma'am, A 1 milligram, B 5 gram, C 10 gram, and D 15 gram.
So Dr. Saba, yeah, patient is healthy already and want to conceive.
Yes,
So
ma'am.
what he will give?
Yes, ma'am.
5G.
5 B.
Before contraceptive, it's a wish that I want to conceive. So when conceive, before planning or want to be planned, it is what? It is?
We give 1 mg of folic acid.
It's
We
a
prescribe.
1 mg. Yeah. The MOH questions are 1 mg. First of all, patient weight. It's not patient is pregnant. We can give 5 milligram in pregnant lady for neural tube defect. But patient want to conceive, so to decrease or to prevent the neural tube defect, we have to start 1 milligram. The answer is A, according to the
Can I
ACUJ
tell
guideline.
something? Can I tell something? Because as far as I know, folic acid must be by microgram, not milligram. So initially preconceptional, we can give 400 to 500 microgram, not 1 milligram. I think it should be microgram. If it is microgram, then 5 micro, I mean, this 400 or 500 microgram is okay, not milligram.
Okay, excellent. Actually, supplementation is this is the exam this way they ask. The thing is that Dr. Monia Jaman is excellently done. They always microgram. So 400 microgram in milligram. If we do the milligram, it will be the 0.4 milligram. If we do in milligram for 400 milligram. So why and what we have to do when exam they ask? So it means there is a value. So female pregnancy folic acid supplementation should be encouraged to reduce risks of neural tube defect. All women reproductive age 15 to 45 should use to take the folic acid supplementation. So it's the, you see, this is the supplementation. This is 400 milligram. So according to 400 milligram, if she counsel, if she is pregnant, so see, women increased risk factor means sometimes women are the immunocompromised. Few categories are there like SCL patient. We have to counsel to take 4 milligram once every daily. But in pre-conceptional stage or willing to be conceived, according to the ACUG guideline, standard is 1 milligram of folate prenatal vitamin. Prenatal vitamin. These are the question we have to remember: prenatal, during the pregnancy, a postnatal, high risk case like a patient immunocompromised. Now want to conceive and you have to decrease the fetal neural tube defect. So we have to counsel the patient that you have to take 400 microgram or 4 milligram, if you say 4 milligram folic acid daily. But before conception, 1 milligram daily prenatal state. Okay, Dr. Monia, clear? Though you are, mashallah, specialist in this field, though I am not the specialist, that's just want to be ensured. Yeah. So immunization question actually very important. This topic is very important, though this is a very large topic, and I will discuss more question today regarding the immunization. Just I want to make sure few words because the question will be posted on the immunization today. I will take the mock also. So see, I will read and I will discuss what we have to. Kindly mute when my candidates enter. Kindly mute. Okay, don't unmute the mic because all will be recording. My 100 there's a 40 plus candidates, so all they willing and sometimes they really hard to attend every day, every time the class session. So pregnancy, preconception immunization, even my exam 2 questions regarding the rubella and varicella. So in DHA, every just remember this topic you will face the exam question. Okay, so we have to clear the basic. We have to clear the basic. Preconception immunization. So means preconception, what we have to choose and what we have to counsel the patient. Influenza. This vaccine, all women who will be pregnant. So all women who will be pregnant during flu season means what? This is the exam question. Patient come to hospital that ma'am, I want to be pregnant in winter season. In ala note, you will get this question. So winter season, patient wishing for having pregnancy, so you have to give influenza vaccine. Vaccine high risk women prior flu season. So in flu season, influenza vaccine we have to be make sure. Vaccination against influenza throughout the influenza season. So throughout the influenza season, we have to make sure this vaccination, but optimally in October, even they mark it October or November, my DHA candidates, recommended by Centers of Disease Council, this infection that we have to mention if this patient want to be get pregnant in October, November, we have to make sure that influenza vaccine. This is the exam paid question. Now measles and mumps, MMR and rubella. We have to do screening rubella immunity. Okay? If non-immune, vaccinate and counsel on the need for vaccinate and counsel for the need for effective contraception. So a patient come to your hospital, want to be pregnant, we have to do immunity screening, but it's not immunity. So you have to counsel the patient what is the effective, this if this pregnant women take this vaccine, because MMR vaccine can't give in the pregnancy. Either we have to give before pregnancy, or some question my MOS candidates they prefer postpartum period. One question they prefer third trimester, but still now in ALA notes MMR vaccine before pregnancy or after pregnancy. It's strongly recommended. Okay, so if non-immune, immunity negative, we have to do counsel regarding the effectivity of the contraception during subsequent month. Okay. Tetanus, diphtheria, pertussis, Tdap. Before that, varicella. Skin, we have varicella, we have to do. If immunite, we have to counsel this varicella vaccination. And as usual, along with the MMR, we can't give this varicella. One question, we can give varicella first trimester. We can give. Okay. If they ask which trimester or patient already taken, unfortunately patient now pregnant, what should do? We have to do counsel, because there is no effect on the baby in first trimester. Question I will discuss later, but make sure measles, mumps, rubella, MMR before pregnancy. Varicella can give first trimester. Tdap, tetanus, diphtheria, pertussis, update vaccination. We have to remember, or we have to give all reproductive age women. Before administration a live vaccine to women, a childbearing age reasonable price should include asking the mom if she is pregnant or could become pregnant in the next 4 weeks. So I have to tell, is there any possibility of having pregnancy within 4 weeks or planning? We have to counseling the mom regarding the potential risk of vaccination during pregnancy before conception. Tdap we can't give, it's a live vaccine. So we have to counsel there is a risk if you conceive, or if there's a potential risk of having vaccination during pregnancy. Routine pregnancy testing before vaccination is not recommended. Routine screening not recommended if absence of pregnancy is reasonably certainly history. So American guideline, avoid in pregnancy 1 month following each dose of live vaccine. So American guideline, we have to avoid live vaccine 1 month. So 4 months. So we have to tell that is there any possibility or true or any concept planning 4 months before you have to complete it. Because in with if you conceive, we can't give this vaccination because there is a loss of risk for taking this vaccine. So prenatal immunization. Okay, prenatal immunization. My dear candidates, prenatal immunization program very important. We have to make sure tetanus, diphtheria, and pertussis vaccination routinely recommended during pregnancy. But what? Tetanus, diphtheria immunization previously immunized means patient telling that ma'am I am immunized or I am get all vaccine doses, full 3 doses already taken. Okay, but if when I'll give, okay, if it is more than 10 years, but like that, pregnant women should receive a single dose, even a single dose in the period of the 36 or 27 weeks of gestational age. Okay. Tetanus, diphtheria, pertussis, each indicated each pregnancy if contraceptive or consecutive pregnancy more than 12 months. These are the indication we have to remember if it is more than 12 months or if it is more than 10 years. So we have to have concern or booster dose we can give if it is more than 5 years. Just remember this chart is strongly. Okay, because this chart will give you how and when we have to keep concern regarding the patient immunization, because if patient already immunized, no need except booster dose in 27 to 36 weeks of gestation. If more than 20 years, we can give only booster dose during pregnancy, or more than 5 years. Okay. If patient on second and third trimester, we can give only tetanus and diphtheria booster dose. Okay. If incomplete or patient and telling that, ma'am, I don't know where either I am taking or not, unknown immunization history against the tetanus and diphtheria, we should undertake or complete series of 3 vaccination. The preferred schedule will be the 0, 4 weeks later and 6 and 12 months after initial dose. So if patient don't know, so it's not during pregnancy time. It's a 3 schedule vaccination, but patient willing to conceive, so we have to take full schedule of vaccination. Okay. But tetanus, diphtheria, pertussis, we can give early part of 26 to 36 of gestation if it is unknown or non-immunized. Patient don't know, unknown history, can give later part. But before that, if still not conceived, we have to take 3 schedule vaccination. So if tetanus, diphtheria, pertussis is not administered during pregnancy, it should be administered immediately after postpartum period, not previously received tetanus, diphtheria, pertussis. So patient tell, ma'am, I didn't get any kind of vaccine, but it's a postpartum period. We have to make sure immediately. Okay. Very high yield topics for the exam. Exam question, very important exam question, life versus vaccine. Actually, they ask this question from the it's not influenza. Actually, the question was okay. Which are the live vaccine contraindicated during pregnancy? So varicella, measles, MMR, zoster, chickenpox, yellow. Just remember the name. We can't give during pregnancy. These are the contraindicated. And postpartum immunization, actually I was searching, it's a very important. We have to remember the postpartum immunization, this full vaccine schedule, just you have to read 2 to 3 times because you have to face this exam question. Postpartum immunization, so MMR and varicella should be given before discharge to protect our non-immune mother and newborn. So MMR vaccine before discharge we can make sure. Okay. Varicella vaccination status actually is recommended for women without, when we give, if there's no evidence of immunity. So first dose of varicella dose if patient on hospital, second dose if we can give 4 to 8 weeks later. So first dose if patient on hospital, and 4 to 8 weeks later we can give second dose. Okay. In routine postpartum visit. So varicella is not at the pregnancy period, it's later, after, during the hospital, baby born, we can give, and later second dose at the 4 to 8 weeks later. And if patient breastfeeding is not contraindicated for administration. Okay. Few questions I will discuss, so it will be make more clear. Question 1 will be discussed with me. Dr. Is Donilda is here? No, here. So it's a Dr. Solomon. Dr. Solomon, question 1. If you able to talk with me.
A 28-year-old woman, a 28-year-old female with history of recurrent pregnancy loss. She comes now to inform you. She comes now to improve her immunity before trying to conceive. What will you give her? I will give her influenza vaccine, being that depending on the season in which we are, she can take influenza vaccine. Then
no, means so Dr. Solomon, first of all, your patient recurrent pregnancy loss. Okay, recurrent pregnancy loss, your patient, and she want to improve immunity, not having any problem for conceive, right, Dr. Solomon? So
Yes, ma'am.
any vaccine that cause recurrent pregnancy loss or anything,
Oh.
we have to make sure to improve immunity. Because patient want to conceive, we have to improve the immunity for not difficulty for having conceive later. So we have to make sure this vaccine, and we are very concerned. Which one?
Would it be immunoglobulin?
What? But which one?
Then, you know,
No, just try. You say influenza. Actually, I said influenza in winter season. If there is a planning, if there's influenza planning of the late season, November, October, but it is not like that. For immunity, we can give, but the actually here main clue, Dr. Solomon, it is recurrent pregnancy loss. It's the main clue. So we have to make sure any vaccination status that it will improve the conceive. There's no risk for loss later.
What about B hemoglobin? Immunoglobulin?
No. Actually, answer is the rubella vaccine. Rubella vaccine, if patient not taking rubella vaccine, congenital rubella syndrome, you know, congenital rubella is catastrophic effect in development of the fetus, is spontaneous abortion. Okay, so we have to keep it mind that rubella vaccine we have to ensure to improve the fetal infection, stillbirth, spontaneous abortion, but it is when patient planning, because patient telling you, sir, I have this, I want to improve. So you have to make sure before that. Okay, clear? Dr. Solomon?
Yes, clear, ma'am. Yes, clear, ma'am. Thank you, ma'am.
Yeah. Second question will be discussed with me, Dr. Hira.
Yes, ma'am. Ma'am, I cannot see it. Can you make it clear, please?
Okay. I said best to take iPad or shortly phone. It's nice because sometimes PC is not available. Yeah.
Okay, ma'am. Question 2, female, her previous pregnancy is stillbirth and now she wants to be, she wants pregnancy and ask the doctor about all the vaccine that she is need before conception and reduces the stillbirth. Ma'am, it's A, rubella.
Okay, excellent. Yeah, rubella. Let's say rubella. Excellent, doctor. Yeah, thank you, doctor. Third question, Dr. Kishori. Doctor.
Okay, I'm here.
Oh, yeah.
Okay, question 3, right? Married woman came in winter to OBG clinic. She want to conceive. Later, what vaccine you should give her before conceive?
So hair strong flu what, Dr.
Yes.
Kishori? Hair strong flu
There is
what?
2 season. One is season, winter season.
Yeah, winter
Yes.
season is the strongest. So we have to make sure which vaccine?
That is influenza vaccine. Because according to winter,
season?
October and November, CDC
we have
recommended.
to make sure. Yeah, yes. Thank you, Dr. Kishori.
Okay, ma'am.
Question 16. Question 16, Ifada, doctor. Okay, that is if Ifada not Dr. Sachma, or question 16. So, Dr. Sachma.
Yes, ma'am.
Question 16.
Pregnancy. Her child's school had an outbreak and she's afraid to get to her child or something. Which vaccine she should get? DTaP, influenza, rubella, and varicella.
First of all, Dr. Sachma, pregnant, her child's school had an outbreak, right?
Yes.
So outbreak means what? Is there any outbreak of any other if you do excluding method?
Outbreak of any disease like
Is there no? If I ask if I say doctor, there's A, B, C, D option. So think which is common outbreak seasonally. It's basic. It's basically we have to think that way. That's it. That is the way I teach my candidates. Outbreak commonly, is there any possibility diphtheria, tetanus, pertussis, any possible? Yes or no?
Vaccine.
No, they said outbreak. She's afraid to get her child something which vaccine should get. So there's outbreak. So which outbreak common in children's?
Varicella?
No. How, dear? Listen, no, never. It's the influenza. Because patients have always sneezing, coughing, outbreak could be common. It's a common outbreak, influenza. Okay, right?
Okay.
Okay. So today I am ending my session. Tomorrow, inshallah, another session. I'll post new schedule, inshallah, tomorrow morning. Hoping I touch today 5 topics, which will make cover every maximum exam question, this topic wise. Okay. So, assalamu alaikum to all. Thank you, everyone. So, concentrate strong. Thank you, my dear.
Thank you, ma'am. Assalamualaikum.